Before starting, I'd like to thank the Saudi Society of Sexual Medicine, represented by Professor Saleh bin Saleh, for arranging this event and for inviting me to moderate it. I'll also extend my thanks to Sprout Educational Platform and for our sponsors, Fering. Our speaker tonight is someone who actually, it is once said that work hard until you don't need to be introduced. And this applies to Professor Danny Rabah. Professor Danny Rabah is a professor of urology, consultant urology and uro-oncology at King Khalid University Hospital, King Saud University in Riyadh. He's also a consultant uro-oncology in King Faisal Specialist Hospital, Riyadh. He's one of the leaders in uro-oncology in the region. He has many contributions, including landmark research in this field particular, as well as in other areas of urology and uro-oncology. I don't want to take long here, but the floor is yours, Prof. Danny.
Thank you, Sultan. Thank you for the kind introduction. Thank you, Prof. Saleh, and thanks to the Saudi Society of Men's Health. It's a great honor that you are letting me into your homes this evening. I hope I can summarize this issue and put some of these controversies to rest. So the objectives of today's talk will be to lead a well-informed conversation about prostate cancer early detection, to optimize the evaluation of men referred with an elevated PSA, and to apply multivariable risk stratification to minimize both over and under treatment. Now, as you all know, in Western countries such as the US, the prostate cancer incidence is the #1 cancer amongst men, comprising nearly 200,000 cases per year. However, mortality, although it is the second most common cause of mortality amongst these men, it only comprises 30.
We can't hear you.
Prof. Danny, we cannot hear you anymore.
Please unmute.
Can you hear me now?
Yes, it's fine.
Okay, apologies for that. Did you hear me from the beginning, or should we go back?
From the objectives.
Okay. So I think the problem is when we go to full screen. So I'm going to make the screen a little smaller, so hopefully you can all see it. So back to the objectives. The objective of this talk is to lead a well-informed conversation about prostate cancer early detection, and to optimize the evaluation of men referred with an elevated PSA, and to apply a multivariable risk stratification to minimize both over and under treatment. Now, in Western countries, the US specifically, prostate cancer is the leading cause of cancer amongst men, comprising near 200,000 cases per year. However, it is the second cause of mortality among these men, and only comprising about 33,000 cases. And within this fact lies most of the problem of prostate cancer screening. Now, prostate cancer is a growing global killer. It compromises about, it is the second most common cause of solid tumors amongst men worldwide, compromising 13%, and is the fifth leading cause of death amongst men with cancer, causing about 360,000 deaths worldwide. Some interesting facts about prostate cancer: the lifetime chance of death of this disease is 3%. The lifetime chance of prostate cancer diagnosis is 17%. The chance of finding prostate cancer at autopsy will range from 30 to 80% based on the age of the person being autopsied. And based on the PCPT trial, we know that the overall chance of having prostate cancer in men over the age of 55 is up to 25%. What is the incidence to mortality ratios? Well, it's very favorable for prostate cancer. It's 8.1. It's about half of that, 4.4 for breast cancer, and it's a starking 1.3% for lung cancer. So there's an 8-to-1 chance that you will be that you will die of prostate cancer once diagnosed with prostate cancer. Now, the real heart of the issue is the number of people dying with the disease far exceeds the number of people dying from the disease. Prostate cancer seldom produces symptoms until it is incurable, and currently available methods cannot accurately distinguish between tumors that will progress so slowly that they will not produce symptoms and those that are likely to cause suffering or death. Therefore, the only option is early detection and appropriate, and under here I really underscore the word appropriate and effective management. Now, the introduction of PSA screening happened a couple of decades ago. In 1994, a pivotal study demonstrated that a number of 4.0 nanograms per ml PSA cutoff was effective in selecting patients for biopsy. Now, how did they come up with this number? For every 100 men tested, approximately 85 had a PSA below 4. The remaining 15 could then undergo biopsy of the prostate, of which 4 to 5 patients would be found to have prostate cancer. Subsequent studies, however, demonstrated that many clinically significant prostate cancer are missed with this cutoff of 4, especially in men with a PSA level in the 2.5 to 4 nanograms per ml range. And I will later demonstrate how this study, unfortunately, damaged the relationship of PSA and screening, and how that number, the magic number of 4 that is ingrained into our brains as urologists and family doctors, was really the worst thing that happened to prostate cancer screening. Now, before PSA, 1/3 of men were diagnosed with prostate cancer died of the disease. PSA, as you all know, became available in the mid-1980s. Although there was overdiagnosis and sometimes overtreatment, however, mortality dropped dramatically, more than any other cancer in humans. This graph demonstrates this, and if you focus on this brown line over here, this demonstrates prostate cancer. This is the mid-1980s, when PSA became ubiquitously used. We got a peak in incidence of prostate cancer. This eventually normalized. Around here, which is around 2010 to 2012, is when the US Preventive Services Task Force decided to give a grade D recommendation. They stopped screening in countries like the US and in Europe. Prostate cancer incidence dropped down to levels even below what they were before the mid-1980s. Now, why is that? Did prostate cancer go away? No, prostate cancer never went away. We simply stopped looking for it. Now, how did this impact mortality? Again, if you look at the US numbers, the yellow line here is that of prostate cancer, and the drop in mortality is significant, about 53% reduction in prostate cancer mortality, resulting from an 80% reduction of metastatic disease at diagnosis. This was only surpassed by lung cancer with smoking cessation programs. So this was a dramatic productive effort in terms of dealing with prostate cancer. The explanation, in addition to screening, was utilization of radical prostatectomy and radiotherapy effectively. Now, how about the incidence of metastatic disease and diagnosis and the burden of metastatic disease? Well, the red line here demonstrates breast cancer, and this is when screening for breast cancer was introduced. And you would notice, even with the introduction of screening, Metastatic breast cancer was pretty much steady throughout the 80s, 90s, and 2000s. Prostate cancer, however, when PSA cancer screening was introduced, we had a humongous drop in metastatic disease and metastatic burden. This affects not only the quality of life of these patients, it affects hospitalization and cost of therapy. As a consequence, some people claim that this disease is not a killer. This led the US Preventive Services Task Force and some European authorities to recommend against PSA screening, and they stopped paying for it. They gave it a grade D recommendation. A grade D recommendation essentially means don't do it. So what happened is we had major headlines, major newspapers around the world, major news outlets, TV stations, CNN, everybody claiming that prostate cancer screening does not reduce cancer death. It's a flawed test. There's no reason to screen, and screening was stopped in most of these Western countries. Now, to continue the sad story of PSA, the consequence of this was in a country like the UK, for example. 65% of prostate cancer detected was in advanced state, no longer curable. They developed more castrate-resistant prostate cancer requiring very expensive treatments. For example, the cost of treating a patient in the last 2 years of his life who is going to die from advanced disease with CRPC is around 240,000 euros. However, if you compare that to the cost of screening, early diagnosis, early treatment, in Europe, for example, the actual cost, not the price, the cost is around 15,000 euros. This was mostly our fault. And by saying our fault, is the urology community fault to start with, possibly the radiation oncologist as well, because we essentially not only did a bad job screening, we did a bad job diagnosing these cancers, and more importantly, a bad job sometimes treating these cancers. Now, I'll refer you to this cartoon. This cartoon is from a paper that was written by two scientists, Ian Thompson, who was a known uro-oncologist, and Isserman, who's a known breast oncologist, and they looked at the issue of screening, generally speaking. If you look at this cartoon, these interval lines, these vertical lines, are screening. If you reach the right side, that means you pretty much lived without dying of these cancers. And if you reach the top, it means you got metastasis and eventually died of these cancers. So there were 4 scenarios. Basically, scenario number 1, where you never caught these tumors. These are what we called autopsy tumors. They would have never caused a problem, never affected your health. The turtles, on the other hand, are the tumors that were diagnosed when they are early and localized, but had they been left alone, they would have never caused problems to start with. And these are the tumors that we don't really want to diagnose by screening. Now, the rabbits, or tumor C, these were the tumors who can be picked up early when they are localized, and if appropriately treated, would have never progressed to metastasis or to death. And these are exactly the tumors that we want to diagnose early by screening and treat. Lastly, there are the birds. These are what we call interval tumors. The patient starts with a PSA of 0.8, the next time the PSA is 1, the third time the PSA goes to 4, and then lo and behold, he has cribriform prostate cancer. That's very fast. Luckily, this is very rare in prostate cancer, but this is the case, for example, with pancreatic cancer, and that's why we don't screen pancreatic cancers. This slide pretty much summarizes the history of prostate cancer screening. Throughout the 90s and 2000s, we implemented it poorly. Older men were overscreened, younger men were underscreened. More importantly, patients with low-risk disease were over-treated, and patients with high-risk disease were undertreated. Despite all these problems, we still drove down the mortality rates by more than 50%. The problem is, by doing so, and by chasing those rabbits, we crushed so many turtles in the process. Therefore, screening none was not the right solution. Rather, we have to screen smarter. So how did we come to this? Well, there were 3 major randomized control or clinical trials that addressed this question. The first was the ERSPC, that was a European trial, and that trial demonstrated that 20-30% relative risk reduction in prostate cancer mortality. The second trial was a Swedish trial out of Gothenburg, Sweden, 42% relative risk reduction in prostate cancer mortality. And the third was the US trial, the PLCO. Unfortunately, this particular trial, which was cited in most of the earlier meta-analysis and the initial recommendation against screening, was a poor study. It was not informative with respect to the question of screening versus no screening. And herein we'll go for some details. The ERSPC was initially published with a 9-year follow-up. Now we have reached a 16-year follow-up. Now, what do we know with the 16-year follow-up? We know that the relative risk reduction of prostate cancer mortality is about 20%. And we know that the number needed to invite the screen has dropped down to 570, and the number needed to diagnose is 18. What does this mean? Well, on the initial trial, when the initial results came out, they said that the number needed to screen was around 2,000, meaning this number dropped to 517. It is no longer called the number needed to screen. We now call it the number needed to invite. By the same token, in the initial trial, the number needed to treat, so you had to treat 48 patients to save 1 life. And we know now that the number has dropped down to 7. And we no longer use the number needed to treat. In fact, we use the number needed to diagnose, because you don't have to treat everyone you diagnose. And that number is now 18. Now, the problem with this particular trial is the treatments were not of high quality back then. The post-treatment follow-up was short. And more importantly, screening started at a later part of these men's life. It started in their mid-60s. This table further demonstrates this fact. Now, initially at 9 years follow-up, as I mentioned, the number needed to screen was about 1,500. This kept on dropping with time, and up to 16 years, it's only 570. The number needed to treat went down from 48 to 35 to 27 to 18. And as we go on, the longer the men live, the longer, the more obvious the result. Therefore, when someone says, I want to screen someone with a life expectancy of 10 years, that doesn't make sense. That's bad medicine. But when someone is expected to have a life expectancy of 15 years or longer, that's good medicine. So if we take the long view on screening, where we calculate the number needed to diagnose, this essentially is the number you have to overdiagnose versus life saved. And this is 48. But if you look at the long term, well, it's 42 divided by 6 life saved. That ends up being 7. So number needed is 7. This is a very acceptable number for effective screening program. Therefore, the initial guideline by the US Preventive Services Task Force that based on an outcome of 8 to 10 years was not informative. Updated guidelines were published at 13 years, were only marginally better. We screened to avoid problems 15 to 20 years down the road. We'll switch gears to the American trial, the PLCO study. As I said, it was a large study, 76,000 men who were assigned to either annual screening versus usual care. Well, usual care back in the United States in the 1990s was essentially doing a PSA. And in the initial trial, 52% of these men actually had a PSA. And only 30 to 40% of these men had a PSA at biopsy. They showed virtually no difference versus the screening versus no screening arm. However, everybody that looked at this paper criticized it. This was not a study of screening versus no screening. This was a study of screening versus less screening, or screening versus ad hoc screening. Furthermore, the actual investigators of the trials went down and digged back into their control group. And remember I told you 52% of these patients in the control arm had 1 PSA? Well, it turns out that more than 90% had 1 PSA test. Therefore, this trial should not be included in any meta-analysis or any decision on actually defining whether screening is good practice or not. Lastly, probably the strongest trial is a very small controlled trial out of Gothenburg, Sweden. The difference with this trial is they started screening at an earlier age. And they showed a quite significant separation of the curves as early as 7 to 8 years. This is much more clearly pronounced 14 years down the line. We know that it showed 41% lower rates of advanced stage at diagnosis, 66% lower in men who were actually screened. More important, the mortality rate was 44% better, dramatic, and then 56% lower in men who were actually screened. So we've demonstrated now that screening does save lives. Now, how about metastatic disease? And what happens when you stop screening? Well, if you look at the yellow curve over here, you can see that metastatic burden has been sharply declining over the past couple of decades. And then this is, by the way, in men who are in their 70s. And then since the introduction of the task force recommendations of stopping screening, we have a steep rise again in the incidence and the burden of metastatic disease. And this is happening across the board, across all ages. So the real problems with screening were essentially over and under screening, and there were also over and under treatments. This is one of the pivotal papers that led the US Services Preventive Task Force to reverse their grade D recommendation when they looked at the patterns of treatment of localized prostate cancer. But the reason I show this paper is not to talk about that. It's to talk about how we, as urologists and oncologists, were doing a bad job. This is the low-risk disease, this is the intermediate, and this is the high-risk disease. So patients with low-risk disease, you would assume that active surveillance would be the best treatment. And if you look here at the curve, the majority of these men were not having active surveillance. Only 10% were having active surveillance. The majority were having radical prostatectomies, more than 60-70%. However, towards the 2010 to 13 date, they started dropping with the prostatectomies and more active surveillance was done. This made more sense in terms of preventing overtreatment. However, on the other hand, we were also undertreating patients with high-risk disease. Someone who had high-risk disease very likely received ADT alone, androgen deprivation therapy alone, didn't receive appropriate radical surgery or radiation therapy. And within this fact is where most of the blame falls on the urological community, or fell on the urological community worldwide. As we started taking note of this, things started changing. We now screen smarter, we diagnose smarter, we treat smarter, things start to make sense. This led to, I wouldn't say a full consensus, but rather most authorities in the US, in Europe, and around the world started embracing screening again. The Americans, for example, all believe in shared decision-making. They differ on the age of which you start your screening, whether it's 55 to 70, whether it's 45, 75 if you had risk factors. This was the case for the Urological Association, the NCCN guidelines, the American Cancer Society, the American Academy of Family Physicians, and the US Preventive Services Task Force. This was also the case in Europe, where their guidelines give us strong recommendations for screening for men above the age of 50 and above the age of 45 if there was African descent or positive family history. And if you had a BRCA2 mutation, you can screen as early as the age of 40. Now, what does shared decision-making mean? Well, there are many guidelines out there with long documents, 10 to 15 pages long, explaining what you should tell your patients about shared decision-making. It's ridiculous to do that. You have to tell them two facts. The first fact is we are screening to find aggressive prostate cancer. We're not just screening to find prostate cancer. We're screening to find aggressive prostate cancer. And in the process, we may find low-risk disease. This should usually be managed with active surveillance and nothing more. Do we have to make more progress? Absolutely. I think baseline testing in men in their 40s to assess future risk of life-threatening disease is very important. Earlier testing for men who are at risk, such as those with African descent, family histories, and possibly testing for older men who are very healthy and who have a long expected life expectancy. Now, the value of establishing an early baseline was addressed by the Malmo aging study. Now, this is a fantastic study that will probably be never repeated again. It wasn't intended to look at prostate cancer or PSA. Men in the town of Malmo donated blood samples in an effort to look at their risks of cardiac disease back in the mid-80s. And a couple of researchers from Memorial Sloan Kettering went out there and looked at all these blood samples and looked at the follow-up of these patients. And it turns out, if you're age 60 or above, and your PSA is below 1, the likelihood of prostate cancer death is below 0.3%. That pretty much wipes out your risk of prostate cancer. It also turns out that 90% of prostate cancer deaths occurred in men with a PSA above 2. Those are the men whose PSAs are in the top quartile. Now, in a follow-up study, they went back and they looked at men younger who were at the age of 45 to 50, and they found the same results essentially. And if you looked over here at that 15-year mark, that's when the curve starts to separate, and that's where we start seeing the diversion in favor of prostate cancer screening. So those in the top decile, top 10% PSA levels for their age group account for almost half of all prostate cancer deaths up to 30 years later. For men in their 40s with a PSA above 1, they warrant more careful monitoring. And for healthy men in their 70s should not be discouraged from being tested if their life expectancy is more than 10 years. Those were the conclusions of the Malmo study. This led researchers in the US to go out and in multiple counties and multiple areas to look at what the average or the mean PSA values are in the 50th percentile. And it was around 0.7 for men in their 40s. And it was about 1.1 in the top quartile, and it was around 1.6 in the top decile. Now, was this peculiar to people from Western countries such as Sweden or the US? Well, it turned out data from Japan was almost identical with almost identical numbers. We wanted to answer that question here in Saudi Arabia. We had a large cohort of our patients that we looked into, and we had identical numbers again. Men who are in their 40s had a median PSA of 0.78. So this seems to be a universal phenomenon, and I think it's a magic number to start looking at early on. And if a man has that number below 1, you can pretty much rest assured that you will not need to screen him for at least another 5 years. We need to forget all about PSA above 4. This has to be a historic number. It is the worst thing that happened to prostate cancer screening. Now, do we have any local data from Saudi Arabia? Well, we set out to look at this back in the year 2006, where over a year we screened close to 2,100 men. These were healthy non-urology clinic patients. They were all above the age of 50 or above 40 if they were high-risk patients. They all had a PSA and a DRE. Now, about 10% of these patients were referred for a ultrasound biopsy. Only 6.2% of them actually agreed to go ahead and have the biopsy. Now, here's the starting information. About 50% of these patients, or 48% of these patients, actually had either locally advanced or metastatic disease. That's a very high number. Denoting that we have a pool of undiagnosed advanced disease in our population that's sitting, and the disease is evolving without being properly identified or treated. How about the actual Gleason score of these patients? Well, more than 55% had a Gleason score of 7 or above. Again, denoting that we do have aggressive disease lurking in our population, contrary to many claims. So how do we screen smarter? Well, as I mentioned, we check an earlier age, and if the PSA is below 1, we check in 5 years. Forget about the PSA number of 4 and use age-specific values. If there are risk factors such as African-American or African descent, family history, BRCA1 or 2 anomalies, we'll screen earlier, probably at the age of 40. We don't test if the average life expectancy is below 15 years, and shared decision-making is a very important element in the process. I'd like to switch gears now from talking about screening to diagnosing these men properly. PSA should not be interpreted in a vacuum. We should use multiple tools. Now, some of the easiest tools are risk calculators that are available online and for free for anybody to use. And when you use these, you can get a better gauge of who needs to be screened, and you can share this with your patient, and who gets a better idea of why and when and if he should be screened. Now, in this patient, for example, the red smiley faces there indicate aggressive disease. The yellow indicate prostate cancer with low-risk disease. You can tell them you have with this particular scenario that have a more than 50% chance of having aggressive disease, versus this patient, for example, who has a very low chance of having high-risk disease. This is not a black or white sort of tool, but it helps in the decision-making process. Many markers have been suggested. Any candidate marker has to improve an existing multivariable gold standard, such as a risk calculator. It has to use a high-quality methodology to be absolutely critical. And the goal is not to identify prostate cancer. The goal is to identify potentially lethal prostate cancer. Now, PCA3 is not available in Riyadh or where I work. I know it is available in Jeddah, I think, by order at some hospitals. The problem is it, again, doesn't give you a very clear answer. It works best at a low threshold of below 20 to give you a good negative predictive value and a high predictive value above 60. The majority of patients, I'm told, lie in between those two numbers. It's falling out of favor, not as widely used as it used to be. Another test, which was developed by the investigators at Memorial Sloan Kettering, is the 4K test. And this looks at 4 isoenzymes of PSA, and it gives you across a linear scale whether your chance is low risk, intermediate risk, or high risk. Again, this is not available in Saudi Arabia. A third test is Select MDX, also not available. However, these are tools that are out there. What is available, and it was ubiquitous actually, is a multi-parametric MRI. I, for one, have been preaching MRI for the past decade, not only for diagnosing prostate cancer and also for managing prostate cancer. The strongest data came out of the UK with the PROMISE trial. The initial study said that the negative predictive value was 7%, that you only miss 7% of cancers if you did an MRI for screening. And the way the study worked is after getting a positive MRI, everybody got a template came with this very strange definition of high-risk tumor, which is only 4+3 or high volume 3+4. When these investigators went back and redefined their their definition of high-risk disease to any 3+4 disease, that negative predictive value dropped to 76%. So essentially, it says you use MRI for secondary screening among women with PSA, you could obviate 25% of the biopsy. However, you would miss 24% of these grade group 2 cancers. So I don't think for everybody. I don't think that MRI screening, use for screening is the wise idea. And the reason I think researchers Can you hear me? Hear me?
Yes, we are good, Prof. Prof. Danny, you can continue, please.
Okay, can you hear me now?
Yes, you can continue, please.
I believe some of us cannot hear you.
Prof. Dadi, we cannot hear you.
Apologies for this. We will try to figure it out.
Salih, you hear me now? Salih, do you hear me now?
Yes, you are
Yes.
back now. Thank you.
Now you're back. Yes.
All right. So I was I'm going to go back to risk certificate.
المعذرة دكتور داني ما نقدر نسمعك. Dr. Danny, we can't hear you.
Prof. Danny, we lost you again.
You lost me again. My God. How about now? How about now?
Yes, you're back.
Okay. So right now. In summary, towards smarter screening, offer screening. Yes.
No.
Dr. Danny, maybe you have a connection issues.
Okay, can you hear me now?
Yes, we
Yes,
can.
loud and perfect.
I'm finishing right now. So the summary is
Sorry, Prof. Danny, we can't hear you.
oh my God. Apologies for this. Really.
Now we can hear you.
Okay. So to summarize, we got to tailor the intensity based on race, family history. All low-risk disease should be managed by active surveillance. Treatment must be high quality, and quality must be measured. That's pretty much it. I was hoping to share a couple of cases with you, but so long as you are unable to, if you can still listen to me, I can share a couple of cases.
Yes, please.
Okay. So, 60-year-old gentleman whose PSA over the past 8 years has gone from 1.1 to 1.8, 2.5, up to 5.93. His free to total ratio is 8%, normal rectal exam, mild LUTS, negative family history. He gets a prostate MRI, no focal lesion, it's normal. The PCPT risk calculator gives us a high-grade tumor chance of 18%. He goes ahead and does a biopsy. His lesion score is 4+3 in 4 cores. Nomogram suggests there's a 90% chance cure by surgery. Now, here's what I'd like to highlight about this particular patient. First of all, he got his first screen at the age of 52. If you notice, his PSA back then was 1.1. And that PSA of 1.1 is a significant number for someone who's age 50. It's a healthy number for one. This is the guy you should be treating. There was a progressive rise in PSA. There's a low total to free ratio. His absolute PSA is 2 times the upper limit of normal. And again, the MRI being normal does not preclude him from a biopsy, because this guy had a normal MRI, and it's not a reliable screening test. My second case is about a 78-year-old man of African descent, multiple comorbidities. His PSA is 4.1. His ratio unfortunately went ahead and did a biopsy. And his lesion score was 6 in 3 cores, very small amount of cancer. The key point is this man should not have been screened. He's of age 75, he has multiple comorbidities, and he had a low absolute PSA for age and a low PSA density. I would have not screened this man. The appropriate therapy for this man is not even active surveillance. It's pretty much watchful waiting. The last case is that of a 41-year-old gentleman. As part of a PSA test, as part of an executive physical program, he had a PSA of 2.6. On repeat exam, it was 2.9. He had a normal rectal exam, normal family history, no voiding symptoms. His PSA density was 0.09 because he had a small prostate. And his risk of cancer, of high-grade cancer, was only 3% on the calculator. Nonetheless, we went ahead and on prostatectomy, he had seminal vesicle invasion. And the key point in this particular case is one young male below 50 is something you need to be very wary of. And you have to repeat the PSA before going ahead and doing a biopsy in such a manner. I'll conclude. I really apologize for the poor connection and the audio problems. Sultan, I'll hand over to you.
Yes, thank you very much, Prof. Danny. It was a very extensive review, simplified, in spite of the connection hiccups here. We have a few questions, if you don't mind, we'll take, and I'll go. The first question here is about, according to what we know the life expectancy of a patient.
Okay. Well, there are many calculators out there that you can use. I know it's not very practical to use these calculators. We as physicians can eyeball our patients many times, and I think medicine is not only a science, many times it's an art, and we have a tendency to try to figure out. There are many available calculators that are available online and easy to use.
We lost you again, Danny. So if I may repeat what Danny is saying, is that there are calculators for life expectancy. They can be used, as well as from experience. You can actually tell whether a patient in his 70s who looks like someone in his 50s with no comorbidities, or vice versa. You have someone in his 60s with many comorbidities, and he walks into your clinic, and you know that this guy is so. But again, there are objective calculators for life expectancy. Absolutely. Another question from the same person is about not understanding the incidence to mortality ratio. The question here, I didn't get it, is 8.1 means that
it's 8 to 1. It's out of every 8 diagnosed, 1.
Yes.
Breast cancer is
yes.
4 to 4. It's 4 every 4. You have a 4.4% incidence ratio.
Yeah, so that's what she was actually saying in her question. You're correct. Yes, 8 patients with prostate cancer, 1 of them will die. So there is another question.
Now I can't hear you.
Can you hear me now?
Yes, I can.
So there's another question about if PSA trend is more important than the value. So how many times we have to repeat PSA to observe trend before starting testosterone therapy safely for hypogonadism? So that is actually more than one question. So if the first part of the question, it says if the PSA trend is more important than the value, how many times we have to repeat PSA to observe the trend?
Well, sometimes the trend is more important, and sometimes the absolute value is important. As I mentioned, if you had a PSA of 1.6, for example, in a 45-year-old gentleman, I'll be very concerned. I'll be very, very concerned, even with that one reading, because that man has a significant risk of getting some significant prostate cancer down the line. Now, does testosterone therapy require a normal, not knowing that the patient is at risk of not prostate cancer? Testosterone therapy will not cause prostate cancer. Testosterone therapy, however, may, in someone who is hypogonadal, exacerbate the risk of prostate cancer. So long as you have no diagnosis of prostate cancer, you're very safe giving it. There have no.
Okay, I believe the issue of testosterone therapy and prostate cancer needs a separate webinar to discuss, but there are many interesting data in this regard. The next question is, what's your recommendation of PSA screening for Saudi population?
Well, I've attempted to answer this question over the past 15 years. It was very difficult to come to an answer. However, for those who are listening who are urologists, I think opportunistic screening is a must. We cannot afford not to screen these patients when they come into our clinic. And that, in fact, is not screening. When they come to the urology clinic, you are really doing opportunistic pickup, and you're the last hope for these patients of picking up prostate cancer. However, do I advise a nationwide screening program? I don't have enough data to advise for such things. But if we look at Western numbers, and if we look how things have progressed over time as societies have matured, we will be seeing more prostate cancer. You have to realize that the average life expectancy in Saudi Arabia was only about 64 until recently. We're now somewhere around 76, I think, and we should soon be reaching Western numbers of 82 and 83, or maybe even 86. As we start to age, as our healthcare becomes better, we start to eradicate better control of diabetes, eradicate infectious disease such as hepatitis and tuberculosis. We will be seeing more prostate cancer. Unfortunately, our cancer registry is lagging behind. We're, I think, about 5 years behind right now, and our data still isn't there. But if you look at the trend, it's a steady climb in ASRs. So I do believe that we will get there. I can't give a recommendation for family physicians to screen in Saudi Arabia, but I strongly do urge all urologists to check their patients diligently.
Okay, so I believe there are no more questions here. If you want to add anything,
I want
Prof.
to add
Danny.
Yeah, I do add one point. The reason the Europeans and the Americans, the family physician practice, stopped screening back then was not necessarily because we were picking up too much cancers, but we were causing too much morbidity for these patients by treating everybody. We as urologists have to realize, if you diagnose a
We lost you again, Danny, here.
active surveillance is a very valid way of treating these patients. And we need to properly diagnose them, risk stratify them, and if they deserve treatment, then they should get radical treatment. If they don't, they should be watched.
There's one more question, is when to stop PSA screening. So if you decide, yeah.
Once your life expectancy is below 15 years of age, I think there's no value of screening.
Okay. So at the end here, we'd like to express our sincere appreciation to Professor Danny Rabah for this excellent update on an important issue, and I believe we will, as he clearly mentioned, in the upcoming year we'll have more aging men, and we need to look smarter in terms of screening for prostate cancer. I'd like also to extend my thanks to the Saudi Society of Men's Health, Professor Saleh bin Saleh, Sprout Education Platform, and our sponsor, Fairing. And thank you everyone for making it to this webinar and for your participation, and hope that we have more of these activities for our non-urology colleague in the future. Thank you very much.
Thank you, and much appreciated.
Thank you, Prof. Danny. Thank you, Dr. Sultan, and thank you for Sprout. This webinar will be recorded, and it will be aired on the YouTube channel for the Society. And I would like just to apologize for all the technical glitches and errors that happened during the webinar. Thank you again for everybody. Have a good night.